All right, it's 4:06. I think we should go ahead and get started. We have about 30 people on the line with us. So yeah, first of all, I just want to start by saying welcome to everyone, doctors, health professionals, and everybody else on the line. My name's Marici Doyon. I'm the digital editor at Chronogram. And today we are meeting with this panel of experts to discuss a holistic approach to women's health. And this is a conversation that we are presenting in collaboration with Columbia Memorial Health. I just want to say quickly, I think everybody is an old hand at Zoom by now, but most of the participants, unless you've manually unmuted yourselves, you are probably on mute with your video off. And basically what we're going to do is interview the panelists. I'll be interviewing the panelists for about 40 minutes. And then after that, we'll transition into questions from the audience. And you can just drop those in the chat box at any time. And then I will skim through at the end and pick out the goodies. So yeah, today we're speaking with a panel of doctors from Columbia Memorial Health, who all work in fields related to women's health, and we'll be discussing how their areas of expertise sort of overlap in what is comprehensive women's healthcare at all stages of life. So I'll just introduce you guys one by one, just very briefly. But if you could wave so people know who you are. We have Dr. Rakel Astorga, who's a breast surgeon, who performs a number of different surgical procedures, as well as breast cancer surveillance, detection, and coordination of care. We have Dr. Ed Marici. Did I say that right?
Yes.
Hi, Ed. Dr. Marici specializes in urinary and bladder issues in women, and is also, I believe, an acclaimed expert in laparoscopic gynecology surgery. On the line, we also have Cynthia Friedman, who is a certified nurse midwife, who specializes in contraception and long-term birth control options, as well as aiding and accompanying women who have pregnancies in their 30s and 40s. And if any of this is off color as I'm saying it or incorrect, please jump in. Actually, the first thing I'm going to have you do is just talk a little bit about your specialties. Yeah, we also have Dr. Shin. Dr. Shin is an orthopedist specializing in arthritis, carpal tunnel, trigger finger, and other similar conditions in middle-aged women. And finally, we have Dr. Gill, who is the mystery man of the hour. He's apparently wearing a pink shirt, but he doesn't have any video, so we're just gonna have to take his word for it.
Yes, I'm waving.
Hi, Dr. Gill. So welcome, everyone. Thank you for joining us. I can only imagine how busy you all are. So to have the undivided attention of 5 medical practitioners is a treat and no small feat. So today we're here to talk about a comprehensive multidisciplinary approach to women's health. So I know I just introduced you all by name and said your disciplines, but I would love just to kick it off with each of you talking a little bit about what you do and how it intersects with women's health from a holistic perspective. Obviously, some of those connections will be more obvious than others, for example, breast cancer. So maybe I'll just call you out in the order I see you on my screen. Dr. Shin?
So as you said, I'm an orthopedic surgeon, and orthopedic surgery is the treatment of bones and joints. And so, you know, if you break something, your orthopedic surgeon usually will fix it. And with regards to women's health, I'm also specifically, as a specialty, the hand surgeon. And hand problems, things like carpal tunnel and trigger finger do tend to be, and hand arthritis tend to affect women disproportionately. So that's where that link comes in. All orthopedic surgeons who take call seem to see a lot of hip fractures, and hip fractures tend to also disproportionately affect women, mostly because women tend to be the ones living quite long, and it is a problem mostly, at least around here, in the elderly. You can also have bad car accidents and have hip fractures, but those aren't the things we're usually seeing. And that's kind of where I think we overlap with some of you, like Dr. Gill there, in that osteoporosis and the hip fractures, we can't do those things without radiology. And so that's kind of what I do. I've been here for 10 years now. And kind of my claim to fame here at CMH is that I came to upstate New York from the island of Kauai in Hawaii, and people wonder why, but I like it here.
Yeah, I wonder if you ever think about that decision on a cold, dreary February day, but everybody has
2010 was a very bad winter, which was the winter that I came here.
Right. Awesome. Well, thank you and welcome. Dr. Astorga.
I am a breast and general surgeon, but 90% of my work is around breast surgery, which involves screening of high-risk patients and dealing with breast cancer complaints, breast complaints, and dealing with breast cancer as well as high-risk screening. And the way in which we kind of overlap is Dr. Marici and Cynthia are the forefronts of women's health at a primary care level, and if they see the need for my involvement, they will refer patients to me. One of the referrals is high-risk patients that need to be screened and appropriately identified as high risk for breast cancer. And of course, Dr. Gill and I work very closely in evaluating the imaging, doing interventions such as biopsies, working together and trying to diagnose breast cancer or abnormalities and figuring out how to appropriately process those abnormalities on imaging.
Thanks for starting to knit that picture together. I'm sure that we'll see over the course of this conversation that your work is kind of pretty interdependent on the different departments. So yeah, next I have Cynthia Friedman.
Hi, everybody. My background's a little different. I am not an MD. I do not have a medical background. My background actually is in nursing. I have a 4-year degree in nursing, a 2-year certificate in midwifery, and a master's degree in midwifery as well. I think the perception for a lot of people of a midwife is somebody who just does home births. That's not the case, actually. I work here at CMH and have for the last 32 years, first 14 as a nurse on the maternity floor and the last 18 as a midwife in the practice of women's health. We take care of everybody from adolescence right through menopause and on. We have a very collaborative relationship with all of the providers on your panel, and we can do everything from birth control, pregnancy. Sorry, I'm in a room where the light goes off if you don't move. And provide care for women for routine problems or issues, or we can work collaboratively with the physicians, either GYN or with our collaboration with Albany Med with maternal fetal medicine for pregnancy. And but we do everything from annuals to OB care to we do have some specialized care that we do as well. I won't delve into that today, but there are things that we can do that are a little bit above. But that's it. I work closely with Dr. Astorga and Dr. Gill with breast issues. I work with Dr. Marici with my patients with incontinence. And I haven't had the opportunity to refer anybody to Dr. Shin yet, but now that I know what she's doing, I will keep it in mind.
Oh, I was muted.
There we go.
I said, awesome. I hope everybody learned something new today. All right, Dr. Marici.
Hello, everyone. Well, Cynthia, you got me beat. I'm only 22 years here. So, but yeah, I've been here since 1998. I originally started just doing routine OBGYN, and now I focus on urogynecology. Became board certified in 2015. What does that mean with urogynecology? It's kind of a nice combination of urology and gynecology. A lot of women issues aren't really separate, so they come to the office with complaints that kind of deal with the bladder and with pelvis, and we're able to treat them in kind of one sitting. But my main focus is now women with stress incontinence or overactive bladder, so any kind of urinary incontinence. We also deal with incontinence, and we deal with prolapse, which means dropped bladders, dropped uteruses, and we have all different ways to remedy these situations, whether it be medication or surgery. And we do a lot of minimally invasive surgery, which is, laparoscopic and small incisions, better recovery. But we also do a lot of just routine GYN care. So while you still see patients, we still take care of the routine stuff. But the main focus for us now is going into the urogynecology and the minimally invasive surgery. Take care of patients with endometriosis. Some of the younger ladies who are trying to conceive may have issues with surgery with that also. But and then we work collaboratively, obviously, with Dr. Astorga. I send her a lot of patients who have breast issues, and Cynthia will certainly send us a lot of her patients who need further evaluation with the bladder or pelvic issues. And that's basically what we do.
Awesome. And then I believe Dr. Gill, you're the last one.
Yeah, so, I'm the dinosaur on this panel. I've been in practice for about 40 years and been involved with women's imaging since 1982. Just to give you a historical perspective, most of the radiologists back in the late 70s and 80s became radiologists because they did not want to talk to anybody, let alone sit face-to-face with a patient and give them their findings or recommendations. So it was somewhat unique to get involved with women's imaging. Most of our modalities at the time were limited and primitive, if you will. The ultrasound was developing. There was no real-time ultrasound in the late 70s. I did my fellowship at Yale, and I was told by the program director that there was no way one would be able to sort of see a technology that allowed you to see different organs live. And breast imaging was extremely primitive also. As a matter of fact, the same equipment that was used for x-raying hands and fingers was used to obtain mammograms. So in 1985, following an act of legislation by the Congress, there were new guidelines that were established by American Cancer Society and American College of Radiology that led to revolutionary changes in imaging devices to diagnose various women issues, including breast cancer detection. And so you know, there was no claim to fame back then to be a radiologist, but we, in collaboration with obstetricians, gynecologists, and general surgeons, we set up the very first comprehensive women's health center just outside Albany, New York, where we provided breast imaging with point of care service, so that after the examinations were performed, the radiologist sat down with the patients and gave them their results, which was very unique at the time in the late 80s or mid 80s, and then made appropriate referrals to depending upon what the patient's needs were. Believe it or not, in 1985, our practice was the very first practice to introduce osteoporosis screening. It was somewhat different how we acquired that information, but that too progressed over time, and some of the devices that are available are a lot more sophisticated than they were back in the 80s. So presently, I'm chairman of radiology here at Columbia Health, and on the breast imaging division of Albany Medical Center. So as a practice, I belong to a multi-specialty group out of Albany. The unique thing about that group is that it was established and started by the radiologist, and we have close to, I think, 500 physicians practicing in various specialties in the Capital District area. And this is home for me. Happy to be here and work with some wonderful people. This is a question you may not ask me, but I get asked a lot, which is that after having practiced all over New York State, why did I end up here after 40 years in practice? Well, the short answer to that is that the medical staff here is very collegial, and it's been the easiest to work with. And there are no turf issues. Quite frankly, when I see the patients, I tell them that Dr. Astorga, Dr. Marici, Cynthia, and Dr. Shin, we are all part of the same network. It's just that our roles are different. And I always tell the patients that if they ever wish me to be the intermediary and facilitate any type of care, whether I offer that service or not, I give them that option to contact me, and then I make the appropriate referrals to the physicians here at Columbia. I can go on if you want me to, but you're better off not letting me loose, because...
All right. We'll circle back around to you.
Okay. All right.
So I want to come back to Dr. Astorga, starting with breast cancer, which is, I don't know, perhaps the disease most directly associated with women in people's minds. So we have routine clinical exams, mammograms, MRIs. It seems like we have all of the tests that we need to nip breast cancer in the bud. I'm sure that that is also a naive statement in ways that I don't know. But my question to you is, do you find that women are reticent to participate in regular breast cancer screenings? And if so, what do you attribute that to?
The answer is perhaps yes. And the two factors that I see that are an issue is, one is time. Women don't take time to take care of themselves because they're busy being mothers and wives and co-workers, and they don't have the time or give the importance to the time to their screening process. The second thing that perhaps I've noticed is, in not a lot of people, but in some, there is a resistance to a screening mammogram every year. And the concern is radiation. And it's a misconception that the radiation is high. And they talk about a cumulative effect of radiation, which is you get a little dose today, you get a little dose in a year from now, and you get a little dose another year. And there's major concerns of that being detrimental for your health. And the amount of radiation in a mammogram is minimal, is extremely minimal. It's the same amount of radiation that you will get by getting in an airplane and traveling from New York to California. And yet we all do it. We all get an airplane. So there's not a hesitation in that sense. And with that statement, to express the importance of how screening mammograms can save lives. The purpose of screening, whether it's a mammogram or breast exam or other imaging, is to find a breast cancer when it's early, when it's easily treatable, and before it metastasizes or travels to other organs and causes death. So mammograms save lives. Certain studies, well published, have shown a mortality decrease, meaning the chance of death of a decrease of up to 40%. It has been challenged, though, the radiation, and it has been challenged in the media, it has been challenged in some medical studies, but the benefit is quite overwhelming. And that needs to be explained and taught and counseled to patients. The second thing is the notion of dense breast on mammography. So patients now, by federal decree, have to receive a letter that states if your breasts are dense. And if so, patients need to know that they should receive an ultrasound of the breast in addition to the mammogram. Because breast density, number one, makes it difficult to see abnormalities on a screening mammogram, and number two, has an increase in the risk of breast cancer by itself. So those are the main things that I would like to share in regards to women being concerned or afraid for screening.
Right, and it sounds like the fear around radiation from the tests is one thing that you encounter regularly. Are there other misconceptions or confusion or questions that you get in your work on a regular basis from patients?
Some is a lot of anxiety in regards to abnormal imaging. Let's say they have a screening mammogram or a screening ultrasound and an abnormality shows up, and patients receive the phone call, your test was abnormal, you have to go see a breast surgeon. The misconception is, oh my God, I have cancer. And patients come, unfortunately, very nervous and extremely anxious. And the misconception is that because your test was abnormal, it doesn't necessarily mean that you have cancer. It means that further workup needs to be done. And even if you were to need a biopsy, the chances of you having cancer is only 20 to 25%. So I think that's one of the misconceptions that we have. The second misconception that I see is on genetic testing, and it's something that I just want to briefly touch upon. And it's that in this day and age, we have the ability to do genetic testing that will identify women who carry mutations that increases the risk for cancer, gynecologic cancer, breast cancer, and other cancers. But since we're on the topic of women's health, genetic testing can be done. It's much cheaper than it was. It's much more available than it was. Both Cynthia and Dr. Marici do genetic testing on women. So if women have a possibility or think that they're high risk for breast cancer or ovarian cancer, they need to come and see us so that we can define and stratify where their risk is. And the misconception is that there's only a mutation that causes breast cancer, which is BRCA1 and 2. And that's not the case. There's at least 30 different mutations that are related with breast cancer and ovarian cancer or breast cancer with other type of cancers. So the identifying this population is extremely important. If we identify a woman when she has a mutation after she has breast cancer, we have failed. We need to identify these mutations early so we can screen them appropriately and identify the breast cancers early.
So I have a question here. It sounds like Cynthia and maybe Dr. Marici are people who are seeing women as part of more on like the PCP women's health side. Is that correct?
Yes.
So I would guess that given the length of tenure that you both have here, that you've seen, you see people move through all phases of their life, from puberty and adolescence to contraception to family planning to menopause. So I guess I would love if one or both of you could paint a picture of how how you work together with the other doctors to take care of women as they pass through different stages of life. Like, do they reach a certain age where you're like, oh, now they should go see Dr. Astorga? Or is there, like, how do the different specialties, how does the team work in concert?
Want to take that one, Cynthia? Or you want me to do that?
Well, I'll start and then you can chime in.
All right.
So we are seeing women from 12 and upward through menopause and afterwards. And we're seeing them for routine GYN care. We're seeing them for problems. We're seeing them for pregnancy and postnatal care. Throughout the lifespan of all women, I may see the teenager first, and we're worried about birth control and STD screenings. And then I see the woman through her pregnancy. And then I see her after the pregnancy for her PAPs and her breast exams. And when she hits 40, if she doesn't have a family history, for her mammos. And what I have found working with this great team that we do have is that if I get back a mammo that is inconclusive or suspicious or that needs follow-up, I usually get a phone call from Dr. Gill. And then my next step is to refer the patient to Dr. Astorga for a consult. If they come in to see us and they have a strong family history, we then talk about genetic testing and offer them that option prior to seeing Dr. Astorga. So hopefully she has those results when she's seeing the patient, because she then makes a plan with them that involves us with following them up yearly, as well as then 6 months later following with her. So we're doing a comprehensive twice a year breast exam and testing that needs to be done. With Dr. Marici, he sort of comes into it after childbirth for some women, or as they age and go through menopause with the incontinence or the prolapse or any issues along those lines. So there isn't a set age where I would say you need to go see Dr. Marici or Dr. Astorga. It would be more based on what their findings are at their exam in the office, and then they're referred appropriately based on that.
Right. And so what's the flow of communication like between the doctors, or like, are you collaboratively kind of like tackling people's cases or making a plan, or I think the behind the scenes of the medical side is kind of a mystery to everyone. So
I can expand on that. I mean, when I see patients, and I have say a patient that I'm going to come in for pelvic pain, I'm concerned about endometriosis, and I'll see them clinically and talk to them, but then I'll go down after they had their ultrasound or their MRI, and I'll go down and talk to Dr. Gill, and we'll go through the films together, and I'll give him the clinical history, and he'll review the film with me, and we'll talk about what we see and what kind of plan for that patient is. So it's really a one-on-one, face-to-face communication with the radiologist and getting, and I'm kind of explaining to Dr. Gill what her clinical symptoms are, and he's looking at the CAT scan, the MRI, and showing me, okay, could be why. So it's fairly personal, and we go down and talk about it. And what's great about our radiology department, Dr. Gill, is he's very interested in not just the film that we're looking at. He's interested in the patient, and what their symptoms are, and how he could figure out from there. So we have a pretty good collaborative way of doing things, I think. We learn from each other, and that's kind of what happens in a sense behind the scenes.
It sounds like the FaceTime, like not the app, like the actual FaceTime component is a really important part of how you guys interact, like going to each other's wings and then, like discussing a particular patient, which is awesome. From the Dr. Gill, actually, when you were first speaking, I had a question about like what the continuity of care experience is like from the perspective of the patient. Like, is there one person that generally is like not their case manager, but like, is there somebody that's consistent through their process, or like how do those handoffs happen from the perspective of the patient?
So, I tell people, and I tell my residents and students that looking at pictures is probably one of the easiest things that I do, because great majority of the patients not related to women's imaging, we don't get to see. We just see their body images, good, bad, or ugly, and there's no face attached to that. So it becomes very easy. So let's say if I'm reviewing a case with a physician on a patient who has widespread cancer, I never sat face to face with that person. So that providing interpretation of that image is very easy. Women's imaging is a little different. First of all, I would say that great majority of the procedures that patients come for, they are anxiety provoking. Breast imaging is only done for one reason and one reason only, and that is to detect not palpable, asymptomatic breast cancer. So it's not done for any other reason, right? So it's anxiety provoking. Yes, people have concerns about radiation, but I think great majority of them, they're just afraid that they might get bad news. So we train our technologists, so it's people who perform obstetrical and gynecologic ultrasounds. We handpick them because it's not only obtaining a picture, it's the relationship and rapport these technologists and coworkers have to develop with that patient to help them through the process. When I see patients, and God forbid if they have to come back for a procedure, I tell them all the time that I've never been on the receiving end. Nobody has ever poked a needle in my body or my breasts in particular. But cognitively and technically, it is the easiest procedure I do. The hardest part of all this is not knowing what the outcome is going to be. Sometimes all the signs are there that it's going to be bad news, and we try to prepare the patients for that, and we try to schedule them with Dr. Astorga or whatever appropriate referral they need. So the team approach, what it does for the patients is that we prepare them to get through that process. So yes, some of them already know that the news and the outcome is going to be bad. However, our staff, the nurses, the technologists, and the go-betweens, Dr. Marici's office and Cynthia and Dr. Astorga's office, there's a lot of communication that takes place before the patient gets back to them. And they're somewhat prepared in their mind. And secondly, we also, and I personally tell them that if they have any further questions from the time they leave the department and the time they go and see a breast surgeon or someone else or an oncologist, we are always there to get their call. And I share my cell phone number with them. you know, sometimes they get calls from their relatives, and we just direct them, help them sort of go through the process. Again, the unique thing, you know, I'm not saying this is the only place, but the way the medical staff is structured, it's very easy to talk and communicate with all the people who are sitting on this panel. You know, we talk on the phone, we talk face to face, we come up with recommendations. You know, Dr. Marici does certain things that can be taken care of without the patient going through a surgery, and we have people on our practice who can provide minimally invasive procedures for fibroids and some of the other issues that occur within the pelvis. So, and then, as Dr. Marici said, that, you know, a few times a week, sometimes scheduled and most of the times unscheduled meetings to get together and go over the images. And quite frankly, sometimes the information that I get from Cynthia and Dr. Marici and then even Dr. Shin and Dr. Astorga, it helps me in coming up with my conclusions. So back in the good old days, there was, you know, people used to say that the national flower for the radiologist is hedge. And I went to a cardiologist meeting for echocardiography, and they showed a slide where a weasel was sitting under a hedge with a waffle in his hand. The chief of the Academy of Cardiologists did not know that there were some radiologists in the audience, but rather than punting things on back to the referring physician asked us a question, and not only based on my knowledge, but the knowledge they impart to me, the final product is much, much better. And sometimes we don't pay attention to certain things that are extremely important to referring physicians. And after being told that that's what they were concerned about, we go back and take another look. And then it doesn't happen all the time, but in some cases our conclusion is a little different. So that interaction, and I'm pretty sure patients have told you they have gone to every specialist there is, but nobody knows what's going on. So there is no one person who will take charge of all the information from laboratory testing and going to the specialists. I don't see that happening here. Okay, now I'll grant you that it's a smaller medical staff, but still, it's a busy medical staff. So the chances of things falling through the cracks are always there, but we minimize that by direct interaction.
Got it.
Yeah, you mind me jumping in here, but I'm just going to say that, you know, Dr. Gill mentioned, you know, the collegiality, and I will absolutely say that this is a small community hospital, and I will say, you know, we interact a lot, and I don't think that's necessarily true anymore. I thought he was going to say in the old days, the doctor's lounge, everybody ran into each other. And nowadays, nobody has a doctor's lounge, but we're a small enough hospital that everybody does run into each other. And there's a little slogan that they used to use, but it's very true for CMH, that it's friends and family taking care of friends and family. So there's the formal stuff, and love it or hate it, we have an EMR system that we've had for 10 years. And pretty much, I will say almost every primary care physician in Green and Columbia counties is a CMH physician. And so we have access to people's records, and sometimes there's certain conditions. Draper veins is one of them, it's a tendonitis, and I'll be seeing that patient, and I'll see a note from, say, Cynthia, and they just had a baby, or that she was seeing them for pregnancy, and I'll know, oh, you just had a baby. It's very common to get that tendonitis with that. And so there's that collegiality of a small hospital, where people really still have personal interactions, which is not true very much anymore in medicine, sadly enough. And then plus we have the EMR system, which if you have somebody with a hip fracture and they were given morphine and they're 89, sometimes it's nice to be able to just pull up the history rather than trying to get it from somebody who's 89 and up in the ER.
Right. It sounds like aside from the in-person collegiality between your colleagues that there's actually like really important pieces of context that you can glean in kind of assessing somebody's condition or diagnosis based on having like a centralized file for.
And the piece that's not here kind of on this panel are the primary care physicians. And they really are the ones that kind of pull it all together. They will probably be the ones to convince them to go for that mammogram. Right. They're the ones that convince them, hey, you know, this is fixable. You should see Dr. Marici. You know, incontinence isn't something that you just have because you've had 3 kids.
Right. God, there's so many things to discuss from here. I guess since we're talking to you, Dr. Shin, you had mentioned earlier that some of the hand conditions, carpal tunnel, which my mom had, trigger finger, there's a bunch. I'm curious why those affect women more. I don't think that's necessarily a life expectancy thing.
It is interesting because I think those of us who were around in the 80s, everybody used to believe that carpal tunnel was a computer secretary typing sort of thing. But actually, when carpal tunnel was first kind of thought to be an occupational thing, it was meat cutters. And then people who worked in factories. But it is absolutely true that women are 3 times more likely to have carpal tunnel than men. And it's for a variety of reasons. And it's interesting because I tell patients this, and it's kind of funny. Dr. Astorga knows, back in the day when you were in medical school, they'd tell you that cholecystitis or gallbladder problems were in women who were female, fat, 40, and fertile. So that meant that they were middle-aged women who were a little chunky, who had had a couple kids. That is so untrue these days. I would say, it seems to me that a lot of people who are 25 are having gallbladders out. And it's similar with carpal tunnel. I think everybody used to think it was a 40-year-old secretary sort of thing. And you would be amazed the number of 20-something-year-olds, and I don't know whether it's from devices. There is some feeling that being lower estrogen postmenopausal causes it, much like breast cancer. It is more common the older you get. Interestingly enough, I always tell people trigger finger is something you see in women between 40 and 70 or guy construction workers. I mean, so I'm not sure what the overlap is there, but I
Googled this, Dr. Shin.
Yeah.
So trigger finger might make you think that it's always the index, but it's not, right?
No,
it could be any finger.
It's actually more commonly in these guys, and the thumb is very common.
So it's generally pretty self-diagnosable, right? Like you might wake up one morning and you're like, oh.
Sometimes. I will say, basically, if you have a finger that gets stuck and you can't straighten it out until you take your other hand and straighten it out, that's usually a trigger finger. There's a problem that's more common in men that's called Dupuytren's, where the finger slowly gets stuck like this over like several years. And a lot of lay people, including my husband, kind of mix the two up. But I will say trigger finger is one of these things. People come in and they say, well, I looked on the internet and the internet told me this. And I said, good.
Guilty as charged.
Yeah, exactly. And then we can fix that. And carpal tunnel, again, is interesting in that I think in the 80s, everybody thought any kind of wrist pain or hand pain was carpal tunnel. And I would still find, maybe more in Kauai than here, people who had surgery and they said, it didn't make me better, it made me worse, didn't fix anything. And I will say, I think and it turns out they had surgery in 85. A lot of people were thought to have carpal tunnel who didn't. But I think we're much better at diagnosing it. But it is also much more common with the kinds of things people do, you know, with their devices.
Right. We haven't really improved our lifestyle for those specific things. We may have only aggravated it. As an orthopedist, are you also dealing with osteoporosis?
Yeah, so it's interesting because there was, the last decade was kind of the decade that we were supposed to really get involved in osteoporosis prevention. And orthopedic surgeons, I think, in some ways, don't feel as though osteoporosis is theirs. A lot of times, the diagnosis of osteoporosis is done via a DEXA scan, a bone density study. That's done by radiology, usually ordered by a primary care physician, or at a women's health visit, like somebody Cynthia might be seeing, and or it's after a hip fracture, and that's sometimes when we get involved. But a lot of the treatment is either with your primary care physician, your women's health person, or an endocrinologist. And so we see the results of osteoporosis, and there was really a push to try and get orthopedists a little more interested in it. But if you're not involved in medicine a lot, you may not realize this, but apparently orthopedists are known for being kind of a little Neanderthal. And the classic is bone broke, me fix. That it's a very simplistic sort of thing. Whereas maybe other doctors are intellectual. The classic orthopedic surgeon was a linebacker, and they can bend metal and put screws in bone. And so there's sometimes, you talked about the comprehensive. Sometimes people get a little lost. It's really important to find out. In some ways, it's really common after a hip fracture to break the other hip in the next 5 years. And it is really, really important that if somebody has a risk of hip fracture, that perhaps we can prevent it. It's like the screening for breast cancer. But also, so that's why we do osteoporosis screenings, is to prevent disabling things like hip fracture or compression fractures of the spine that make you look like a hunchback. And these sorts of things are kind of multidisciplinary, and so they have a tendency to either get lost or only kind of come up, it's sort of like a lot of times colonoscopies are done when somebody has symptoms, but they really should be done purely as screening. And it's the same thing with DEXA scans. A lot of times we do them because somebody breaks a bone, but we really should be doing them to prevent them, to do the things that help prevent them from breaking that bone that then puts them in the nursing home and then earlier demise.
So things I learned recently from my own mother's experience. Menopause causes a drop in estrogen, which can lead to a drop in bone density, which puts people at risk for osteoporosis. Saying that aloud to consolidate it in my own brain, and for anyone listening that didn't know, it sounds like from what you said that people might get diagnosed or screened for osteoporosis from a variety of different sources, either their gyno or their PCP, and that it sounds like the treatment will go back into whoever requested that screening, into the realm of whoever requested that screening. So if it is if you're perimenopausal, or it would be a treatment plan that you make with your gynecologist, or if you broke a hip and you don't want to break the other one, then you're talking with your PCP. Does that sound right?
A lot of times, yeah, a lot of times.
Right.
And it's interesting because sometimes it gets forgotten that men can get osteoporosis as well, but women tend to get it earlier, plus they live longer.
Right.
And the sad thing, I don't know, I'm not going to say that everybody online here, but already everybody online here has passed their peak bone mass. Your peak bone mass, usually you reach somewhere between 18 and 30. Usually it's around 25. And so then you kind of maintain until you hit menopause, and then it drops off.
Right.
And so, if you are a small frame, they actually use 127 pounds as the cutoff. If you're under 127 pounds, if you're a smoker, if you drink much alcohol, if you're a small framed white woman or Asian woman, then just being postmenopausal and having two of those things is risk factor. Previous osteoporotic fractures in your close relatives. And it starts to cover just about everybody. And I say, you could be a 300-pound black guy, and if you live long enough, you will get osteoporosis, but you're going to get it much later than your 100-pound white woman who has 2 glasses of wine every night.
Right. Awesome. Well, I never thought I would say this, but we have 5 minutes left, and I want to make sure that we get time to talk about pelvic prolapse.
Very exciting.
I haven't forgotten about you, Dr. Marici.
Okay.
So urogynecology kind of sits at this intersection of disciplines, urology and gynecology. You mentioned that before. With women, those problems are often intertwined. Can you just briefly tell us what are some of the most common conditions that your patients present with? Because I think this is maybe one of the lesser known disciplines or cross disciplines.
Yeah, a lot of times patients don't know even who to see because they'll go to a gynecologist because they have a prolapse, they're not sure what it is, or they have a bladder issue, not sure to go to the urologist or gynecologist, but I kind of play both those roles. A lot of times what I see is patients will come in as, I kind of make a joke, it's really not a joke, but it's really what I've seen women go through their kind of their years since I've been here, and they've delivered, and I kind of see what, unfortunately, having multiple children can affect the bladder, can affect prolapse, and then they come in and I see what their babies, in a sense, have done to them. But they will have a prolapse, they'll come and they're not sure what it is, they'll feel something bulging out the vagina. Some people come in scared thinking it's a mass. Other people are just, what is this? It's bothering me. And what it is that you can have, it's pelvic floor prolapse is kind of broken into 3 compartments. One is where the bladder itself kind of pushes on the support structures of the vagina and pushes into the vagina. It's almost like a hernia. And then they're gonna feel something bulging out the vagina. It's uncomfortable, and they will have bladder symptoms. Also, the uterus itself can with support structures kind of weaken and kind of loosen up, and the whole uterus can actually start coming out the vagina. And sometimes the bottom of the vagina can start bulging out. And I guess they come in scared and worried and concerned, but it's basically a huge quality of life issue for these women. I mean, a lot of them are having incontinence, a lot of them are having overactive bladder symptoms, getting up multiple times at night to go to the bathroom, just pain or pressure. So it's nothing, I usually calm them down and say, none of this is going to harm you, but we can make your life better. And you can make it better by a lot of different ways. I mean, some women who are maybe older and don't want surgery, we can use pessaries, which are little rubber devices we actually put in the vagina. It pushes things back up, and it actually resolves their symptoms.
So what's happening is the connective tissue, what's happening that the organs are?
Well, yeah, the real thing is there's something called the levator muscles that kind of hold up everything. And when those levator muscles kind of weaken and stretch out, and you lose some nerve innervation, then what we call the endopelvic fascia that holds everything together is more strained. And so all that gets stretched out.
And I assume that having children contributes to that.
That's a huge factor. There's genetics behind it. Some women can have 7 or 8 children, have no problem. But in general, it's multiple pregnancies. Smoking is not a good thing for that. Obesity can make it worse. Lifestyle, where some women are working hard jobs, or they're lifting and straining all the time. Those things can bring on the prolapse.
Right.
But we can fix it both with pessaries or with surgery. The surgery is minimally invasive, and we do it laparoscopically and vaginally. And most of the time, they're either home the same day or the next day.
Wow. Do you get a lot of, surgery sounds like a big, scary, invasive thing. Do you get a lot of resistance, or do people kind of chill out when they realize what you just said?
Well, I think, some people are, dead set against surgery, but other people, when we have the long conversation and they don't really like the idea that, geez, I'm going to have a pessary the rest of my life, and they're on the younger side, they say, we start talking about surgery. And what I find is that after the surgery's done, they usually say, wow, that was a lot simpler and easier than I thought. And I wish I would have done it sooner. I hear that a lot. And then I have their friends come in and say, hey, she said it wasn't that bad. So
right. It seems like people, there's some sorts of routine, like a hip replacement. People seem to say that too now. I don't know.
Well, the technology has gotten so much better. And, in the olden days, we used to make these huge open incisions. People were laid up for, weeks on end. And now it's just a ball game.
Amazing. And one last question about that. Is there anything like preventative that women can do, like exercises or?
Yeah, so we had, I mean, there's the classic Kegel exercises that probably everybody's heard of. But one thing that I stress to patients is that they did a study, it showed that 70% of women do not do Kegel exercises correctly. So we actually have a physical therapist in town, which we're very lucky to have, who specializes in women's physical therapy and pelvic floor prolapse. And she is wonderful. Her name is Lauren. She works on Fish and Game Road in Hudson. And I think that getting in there and just learning how to do the exercises correctly will make a huge difference in preventing incontinence in the future, and even possibly prolapse.
I got one question from a reader that I'm not sure, Dr. Marici, if this will be for you. Somebody asked, what can be done to prevent vaginal atrophy in postmenopausal women?
Sure. Yeah, that's my game. Yeah.
Right. Okay.
Yeah, no, absolutely. I mean, the vaginal atrophy is very common in postmenopausal women. I can't tell you how many women come in and complain that they feel dry. They almost feels like something in their vagina. They have problems with intercourse. As much lubricant as they use just doesn't matter with intercourse. So estrogen cream. I mean, estrogen is the solution. Creams are great. There's rings. There's all kinds of estrogen that we can use. And I will tell you that most women, after they use it, go, oh, wow, huge difference. Now, then the biggest concern they always have with that is the safety, you know, and certainly probably Rakel could talk about that, but I will tell you that vaginal estrogen cream, there's very minimal systemic absorption. I don't think there's any studies that really show that there's a huge increase in breast cancer by no stretch of the imagination. And it's a huge quality of life issue. And most women do very well with just taking some estrogen cream and have, you know, just a great improvement in their quality of life.
I think if it was a spike in breast cancer, Dr. Astorga would be talking to you.
No, he's absolutely right. Vaginal estrogen shows no increase whatsoever in the risk for breast cancer.
So a topical application is a local solution.
Absolutely. I'm always, I think in the long run, there's been a disservice done to, you know, the use of estrogen. It's almost become taboo and, oh my God, you're going to get breast cancer. But there are so many good benefits to it. It reduces your risk of urinary tract infections. I have women who have chronic urinary tract infections. We put them on estrogen cream, and I don't see them anymore. They said they're fine again. So it makes a huge difference.
Awesome.
This is where these multidisciplinary things kind of come up. So from the orthopedic standpoint in osteoporosis, we love hormone replacement therapy. We think it's great, but many people are afraid of it, especially because of the breast cancer thing. And so for certain people, it is great. Certain people, it's not indicated. Topical stuff like Ed's talking about, much less risky. But another joke we have as orthopedists is that we want kids to go out and play in the sun. But all the dermatologists say, no, slather them with sunscreen. But we're like, no, they need vitamin D and they need to stop drinking the soda and drink the milk. So, but then everybody's like, what do you mean, cow's milk? You know, and so everybody's got a different, you know, where it all kind of links together.
Right. Well, I have to say, it seems like you guys all know each other really well and that you have good professional and personal rapport, and that is probably a tremendous comfort to the patients that have to go through your walls. Hold on one second. One quick follow-up. You were talking about estrogen topicals. Somebody's doctor had recommended a progesterone cream for vaginal dryness. Why? And they're just asking why progesterone instead of estrogen.
I've not had any experience in using progesterone cream for vaginal dryness. Cynthia, have you?
No.
Yeah, I've not heard of that. I mean, progesterone is really technically an anti-estrogen, so I'm not convinced it would, you know, work well. I may be wrong, but I've not heard of that for vaginal dryness. I've heard, especially pregnancy and things like that, where we use progesterone to, I don't anymore, but to carry pregnancies, but not for vaginal dryness that I'm aware of.
She has a family history of estrogen positive breast cancer, so maybe they were being extra cautious. I don't know.
Yeah, I guess that's possible. There's other creams out there that like DHEAS cream, but that's supposed to be converted to estrogen once it's applied. But yeah, I'm not convinced it would work very well.
All right. All right. Anyone on the line, this is your last chance to ask a question in the chat box. It's 5:05. I want to let these doctors get back to their days and their families. All right. I think that's it. There's no clamoring to ask questions. So
if I may say for Susan, for the question that we had about the vaginal dryness, if estrogen is a problem because of the family history of breast cancer, something that can be used in a holistic fashion is coconut oil for vaginal dryness. And EMU oil, EMU oil. It's also something that works well for vaginal dryness if progesterone didn't work.
I'm just seeing that questions come up. So the estradiol and estriol, those are all forms of estrogen. So those are all fine. I think Kitty had that question.
And again, vaginal estrogen, no risk for breast cancer because it's not systemically absorbed. So if you have a family history of breast cancer or you're concerned of your risk for breast cancer, vaginal estrogen is totally okay to use.
And to be clear, Dr. Astorga, you're saying that as compared to like hormone replacement therapy, right?
Correct. I mean, we do know that oral systemic, meaning a pill that you take,
right,
does increase your risk for breast cancer. Hormonal replacement therapy does increase your risk, but vaginal topical estrogen does not.
Topical should be okay.
Correct.
Cool.
Can I just add one thing into this conversation? Is that use it or lose it. The longer that you go without stimulation to your vagina, the more difficult it will be to resume intercourse further down the road. So what I tell people is that, 2 to 3 times a week, there should be some vaginal stimulation. It doesn't, I don't know how in depth I should go, but it doesn't have to be with a partner. It can be by yourself. It can be with a toy, but something that stimulates the vagina to produce moisture and to keep it healthy.
You heard it here first, folks. Use it or lose it. Awesome. I think the chat has gone quiet. All of you, thank you very much for taking the time. It was definitely an interesting and enjoyable conversation. So yeah, and we are recording this. I hope you're all okay with that. We're going to be posting this as a video with a little write-up on Chronogram's website. We have some people that wanted to tune in but weren't able to make it. So that's a way that we have to make it available to them. All right. And thank you all and have a great evening.
Thank you.
Thank you.